This 22 years old male presented with abdominal pain for 3 days. There was abdominal distension, and abdominal examination shows rigidity and distended abdomen. CT showed pneumoperitoneum, and there was pyloric thickening, and free fluid was there. Bowel loops were edematous, and we did laparoscopy in this patient. The laparoscopic entry is very important, so you have to use Palmer's point entry. Normally, if you are going through the umbilicus, then invariably you will be entering the bowel loop. So you have to enter very carefully through Palmer's point. That too, you should not insert the trocar too much deep inside. It can cause perforation to the stomach or the colon. So carefully enter the peritoneal cavity, and after putting 5 mm scope, you can see there is hardly any space between the bowel loop and the anterabdominal wall. So we gently used telescope to increase the space and then increase the pneumoperitoneum, and carefully introduced another 5 mm telescope in order to create the space between the bowel loop and the anterabdominal, which was stuck to each other, and then only we got some space and pneumoperitoneum. So after getting the space and pneumoperitoneum, then we introduced additional ports in order to get the surgery done. So any perforation case, the first step is don't go and look for the perforation from the beginning. So you just concentrate on giving lavage. So you have to reduce the sepsis to the patient immediately. So as soon as you enter into the peritoneal cavity, you try to give lavage. You suck out all the collection which is there in the peritoneal cavity, and you can see the perforation here. So you suck out the pus and fluid which is there in the peritoneal cavity, and give lavage by using a lot of normal saline. While doing peritoneal lavage, you have to be very careful not to injure the inflamed and friable bowel loops. So use soft instruments, and you have to use the head down, head up, right lateral, left lateral tilt effectively in order to get the best possible exposure. So you focus on the right subdiaphragmatic space, right subhepatic space, left subdiaphragmatic space, and left hepatic space. And if you come down, you focus on the right and left paracolic gutter, interloop collections, and pelvic collection. So all these things has to be thoroughly washed and cleared. And regarding the falciform ligament patch for duodenal ulcer perforation closure, we use it regularly, and we are using it for the past 10 years at least. And this is very nice patch to do the duodenal closure, because as soon as you release the falciform ligament, it immediately falls over the perforated area, and it actually lies over the perforation site. There is no need to put additional ports to bring the falciform to the proper place for the closure of the perforation. If you are using Omental, then sometimes you may need to place additional ports to keep the Omental in place at the time of suturing. That is not needed. And sometimes if it is a delayed perforation, the Omental will be like a mass, and it is difficult to bring the Omental which is rigid, and it is difficult to place it over the perforation while closing. So this falciform ligament is very useful. And we take 3 sutures normally. We are using this is a 2-0 PDS suture. First suture is at the center of the perforation, and while taking this suture, you have to make sure that you are not including the posterior wall of the duodenum. And then one more suture on the upper aspect, and the third suture on the lower aspect of the perforation, and you keep it without tying, and after that you place the falciform ligament over the previously placed suture and start tying it one after the other. So first we are done with the far away suture, then we are coming now to the central suture, and then we'll come down to the third suture. So normally people used to close the perforation and then keep the omental patch or falciform patch over the suture area. But here we always take sutures and keep the falciform or omentum over the suture and over the perforation, and we'll tie it around the perforation. We put another 1 or 2 additional stitches in order to secure the closure, and the closure is almost done. So after doing this closure, then you have to go for final wash. You have to concentrate again to give the perfect possible wash to the peritoneal cavity. I feel that this is the most important step in any perforation closure procedure, because antibiotic will not cure the disease. It is a wash which is going to cure the problem. And you have to use the head down, head up, right lateral, left lateral tilt effectively to get the exposure. And we are placing 2 drainage tubes, one in the pelvis, one at the perforation closure site. And we complete the procedure. Thank you very much.